afternoon. We hope you enjoy your lunches and really get a lot out of our presentation today. So I'm Dr. Amy Armstrong, and on behalf of the Creative Educational Concepts, I would like to welcome everybody to today's educational activity entitled MEK Inhibitors in Neurofibromatosis Type 1, Nursing Contributions to NF1-PN, which is short for Plexiform Neurofibroma Management. Today's program is supported through independent educational grants from Alexion Pharmaceuticals and Springwork Pharmaceuticals Incorporated. Get slides moving. There we go. Today's program is brought to you by Creative Educational Concepts, an award-winning accredited provider of continuing education for clinicians worldwide, and has a variety of activity credit types. Very fascinating. All right. If we can move on. There we go. Today's activity will include discussions of products or devices that are not currently labeled for use by the US FDA. And we will try to point these out, but take everything with a grain of salt here. All right. Again, my name is Amy Armstrong. I'm a pediatric oncologist at Washington University in St. Louis, associate professor of pediatrics. I direct our solid tumor program and co-direct our AYA sarcoma program. It's really just a pleasure to be here today, and I'd like to introduce the other members of our panel. All right, so we have Dr. Aarong Kim from DC Children's. Yeah. Why did I not get a little answer? There we go, much better. She is the Director of Clinical Research at the Division of Oncology and the Lexi Spite, if I said that correctly, Professor of Pediatric Oncology, and has been a colleague of mine for the past couple of years and absolutely a pleasure to work with. As has, there we go, Sanita Borgic, who is one of our nurse practitioners. I think the really cool part here is she works more predominantly on the adult side, and it's kind of our yin and yang at WashU between pediatric and adult patients with the treatment of plexiform neurofibromas, and really brings a great breadth of expertise for the management of MEK inhibitors, and especially in this patient population. There we go.
Thank you.
All right, and then here are our disclosures, which I'm not going to go through one by one, but for your viewing pleasure. All right, the learning objectives for today, we have 3 of them. The first one is to distinguish key characteristics of NF1 clinical presentations and disease progression across the patient's lifespan, including genetic etiology and multisystem pathophys of NF1 and the impact of early and accurate diagnoses. Secondly, we want to provide patient and caregiver education on MEK inhibitors and the management of NF1-associated plexiform neurofibromas in pediatric patients. And lastly, to examine the role of oncology nurses. So thank you guys for all being here today and everything that you do. But in the comprehensive care plans, including disease monitoring, treatment personalization, toxicity management, and really that transition of care from pediatric to adult, as they move through across the lifespan of the patient. So during this program, you'll be able to send in questions via a question tab, very fancy. We'll try to kind of man the questions as they come through here and take them as they come. Otherwise, as we get closer to the end, we'll also address questions. And now I think we're ready to get started. So hitting the first objective here is really clinical features and diagnostic criteria. And I'd say throughout my training, we're definitely seeing a higher proportion of patients who have NF1 in the oncology setting because we have more treatment options for them. So I think it's really important to understand that this is a head-to-toe genetic disorder. There are a couple of neurofibromatoses. The topic for today is to focus on NF1 or neurofibromatosis type 1. I just really want to highlight that the clinical things you can see in the setting of NF1 are really head to toe. I know it's a pretty busy slide, but if you can focus on the left-hand side here and really understanding what a patient could experience. Also to add that it's an extremely common disorder. So 1 in 2,800, we quote 25 to 3,500 individuals worldwide will have NF1. And it's the most common cancer predisposition that will come about here. Specifically, you can have manifestations in the brain or the eye. You can have learning disorders, autism spectrum, ADHD. A lot of these kids may have IEPs in place at school or 504 plans. Additionally, I know it's a little small for us to see exactly, but you can see cardiovascular issues, blood pressure problems, vascular problems, even like renal artery stenosis. So a patient may have a really high blood pressure due to an abnormality within their vascular system and not necessarily a problem of a medication. Understanding endocrine issues, precocious puberty, bone health, skin manifestations. We'll highlight some pictures, so I'll save that for a little bit. Bony abnormalities, particularly in the youngest of children, where you'll have issues with bone health or the bone formation, and really just head to toe to understand that there's a lot going on with patients who have NF1, and so to be cognizant of it as we move forward with treatment is really, really important. Now moving on to genetic considerations, NF1 is an autosomal dominant tumor predisposition syndrome. And what that means is if you have a parent who has NF1, there's a 50-50 shot that the offspring or the child is going to have NF1 as well. We know that it's caused by a mutation on chromosome 17q11.2, a heterozygous mutation, and then for those who have the mutation, it's 100% penetrance, meaning that you are going to see some clinical manifestations and show signs of NF1. Now, not every person is the same, and even within families, one patient or one sibling may be very different than the next or their parent. Also interesting is that it's diagnosed in about 50% of patients who have absolutely no family history. So sometimes those kids are a little bit later to pick up by their pediatricians and really rendering the diagnosis, while others will definitely have a pretty strong family history that we'll see. In clinical issues as problems, as we've already alluded to, really a wide variation throughout the body, and then amongst patients, a really wide variation as well. So we say there's really no good genotype-phenotype correlation, so one genetic mutation isn't going to all of a sudden lead to all these clinical things that you'll see, but there are a lot of things that patients can be at risk for. The development of some of these clinical features definitely evolves over time. So an infant with NF1 is not going to have all the clinical manifestations at birth. You're going to see things evolve as that patient ages, and especially as we get to adulthood and what Sunita sees in clinic, a lot of the cancer predisposition will come out a little bit more too. So other things we have to think about for our screening processes. But by and far, the most common thing we'll see, and usually the earliest, is something called a café au lait macule, which I'll show you on the next slide of a picture of what that looks like. Café au lait, for those French-speaking people out there, is kind of coffee with milk, so a light brown color to the skin. Some of the bony abnormalities will be seen in young children, pseudoarthrosis, and then the plexiform neurofibromas. We really feel like are congenital tumors and that patients are kind of born with that start of formation. I won't get too much into the pathophys of that right now, but then the plexiforms tend to evolve as the patient ages. And then as we're hitting preschool, kind of kindergarten age, some of the learning deficits may manifest. Now, not everybody is going to have them, but problems with certain school, autism spectrum, ADHD, that may come about. Motor speech delays, and then optic pathway gliomas start to, the risk for that develop. And then as we're hitting more adolescence, skin fold freckling, leash nodules, which I'll show you a picture of, scoliosis, skin neurofibromas, neurofibromas located against the spine, paraspinal, and then the brainstem gliomas. And then adulthood, really some of the malignancies, so a malignant peripheral nerve sheath tumor, which unfortunately if develops is the #1 cause of death in patients who have NF1. Breast cancer, so I believe they start their screening at the age of 30 for those who have NF1, and even the high-grade gliomas will start to evolve in adulthood. So we always say a picture is worth 1,000 words, and I think understanding what café au lait macules is really important. And also understanding in the context of NF1, you need at least 6 of these throughout the body. So a lot of patients, a lot of kids, even adults are going to have hyperpigmented skin lesions. That doesn't mean you have NF1. But if you're seeing more of these, and these can continue to develop over time, a little red flag needs to go off, like is something else going on right now that's causing this to happen? And so often the first sign and present in about at the age of 1, about 80% will have already that 6 number, which meets diagnostic criteria. And then the size is a little bit smaller for those who haven't gone through puberty and a little bit larger for those who have gone through puberty. Also, we'll see skin fold freckling, so in the armpit region and also in the underwear line, that's present in about 75% of patients. Usually comes about a little bit later than the café au lait macules in younger children. The eye abnormalities are part of the diagnostic criteria, so leash nodules really require going into an optometrist or an ophthalmologist for evaluation. You're not going to be able to see them in your regular clinics. It requires a slit lamp examination, and so if somebody is being screened for NF1, we always do an ophthalmologist referral for evaluation. Additionally, choroidal abnormalities can be present, and those require very sophisticated modalities for detection. Moving forward, you'll see the dermal neurofibromas. So these are little skin outpouchings. Usually come on later adolescence and then definitely into adulthood. So a young kid may have a few or none of these, but by the age of 30, they could have hundreds kind of scattered throughout their body. And sometimes we'll see in clinic the adult who has NF1 and then their child, and you can kind of see the difference for some of these manifestations where they'll be. Bony abnormalities are what the kind of x-rays, I would say, are showing at the top there, so the tibia bone and then the sphenoid. And then really the bulk of today's talk, and we were just talking today, it's sometimes helpful to have more pictures, but what a plexiform neurofibroma looks like. So I really want you guys to focus on the kind of the white tumor bulkiness right here. I always call it like a bag of worms when we get an MRI. It's not well circumscribed. It all comes off the peripheral nerves because the Schwann cell that creates the nerve becomes tumorigenic and kind of brings all these other cells into the their microenvironment starts to kind of outgrow this tumor. I know Irang's going to talk about that a little bit later, but to understand that's an MRI, what that look like for an actual patient. You might see the bulkiness here. You can have PNs that are on the arms. You can have them on the face. You can have them internally too, where you wouldn't be able to see it from the outside. So really having that high clinical index of suspicion for symptoms. And then to the right, the optic pathway gliomas, which are most common in the youngest of children. We really try to figure out if it's impacting vision and if it requires treatment. All right, so periodic reevaluation of needs of kids who have NF1. So if you've actually rendered the diagnosis, it's really important that these kids are plugged into a clinic that has expertise in NF1. I feel fortunate at WashU that we have a dedicated clinic in our neurology division that sees all patients with NF1, and then I'm really seeing the patients who need treatment or at least need evaluation to consider if treatment is needed. I know some centers are a little bit different, and so an oncology clinic may be housing all the NF1 patients as well, but I think yearly evaluations to look for the physical manifestations and the complications that patients have is really, really important. That involves eye health, skin health, cardiovascular system, bone health, neurodevelopmental, and then definitely growth and endocrine. For the diagnostic criteria for NF1, I'm not going to go through each of these. I'm just going to say that it's evolved over time. And so our most recent criteria that's out there in 2021 basically says if you have a family member who has NF1, either from a clinical or genetic diagnosis, and then you have one of the features, which I'll list out here, you have a diagnosis of NF1. If you don't have a family member, you need at least 2 of these features in order to be considered having NF1. Again, the most common thing we'll have, which is part of the diagnostic criteria, is cafe au lait spots or cafe au lait macules. Another one is freckling, again, in the armpit or the groin region. Having 2 or more neurofibromas or just 1 plexiform neurofibroma. So if somebody's coming into clinic to see me for the first time with a plexiform neurofibroma and cafe au lait macules, they by definition will have NF1. Optic pathway glioma is part of that criteria. The leash nodules are choroidal abnormalities, so again requiring an eye exam for determination, a distinctive osseous lesion. And then lastly, if you actually identify the NF1 genetic variant, that would lead to diagnostic criteria if you also see a clinical manifestation. Care for these patients, as you guys can probably appreciate me just going head to toe for all the things that we're seeing, really requires a lot of different people to be involved. I'd say at WashU we have champions for this, so if we hit a certain manifestation that requires help, there's usually somebody in that division who really has an interest and desire to help and care for patients. But it requires, certain type of surgeons, obviously oncologists as we're sitting up here, genetic counselors, social work, neuropsychiatrists, just a lot of people that can really optimize the care for a patient who has NF1. And you really need to have that champion in the middle, so definitely a patient and caregiver, but also that provider who can really advocate for the patient and get them the help that they may need. And then I want to take you to a story from Rennie Moss, and I won't go into a ton of details here for everything that she does, which is absolutely amazing, but she has 2 children and her husband who have NF1, and just really understanding her journey and the journey of her family I think is really important. Challenges for certain patients to access care, get the care that they need, get to a diagnosis. These are the things that these families are really facing, and we'll hit the video from her next.
The challenges of accessing a neurofibromatosis clinic or a clinic that is well-versed and experienced in neurofibromatosis care, access to specialists that may be needed in that continuum of care is very, very hard in our country, in the United States specifically. We were very fortunate when we received our diagnosis. 5 minutes away was one of the best NF clinics in the country. So it was not our experience, but in my 10, 11 years of managing this with my family and engaging with parents and patients in the NF community, our experience is very unique. Most families do have to travel at least some distance, sometimes a long distance, to access the care they need. That can affect your job, that can affect your employment, that can affect your school, that can affect your pocketbook, your finances. And we're also a middle-income family with insurance. Not everybody has that ability. So If you need an MRI and you're 4 hours away, having the ability to do that, but then having to go back to get the results of that, or having to come do, blood work or a scoliosis scan or a DEXA scan, if those appointments can't be coordinated, that's a very expensive both time and financial commitment for that patient or that family to be able to travel back and forth and do that. And with NF1, because there are so many learning disabilities and sometimes multi-generational diagnoses, the ability to maintain successful employment is sometimes a challenge. So you add the distance and the financial toll it takes on a family to be able to access that care, along with the ability to maintain employment, to be able to do that. It is a huge stressor and frustration.
So hopefully you guys were able to appreciate the thoughts from her video, but I think, having dedicated NF1 care in your backyard is not possible for a lot of patients and families. So having a dedicated center that they're able to travel to is great, but there's obviously a hindrance if you're multiple hours away and for the care that you need. We saw some questions pop up, so I might try to address them before we move on to a case example here. The first question is the variability in penetrance and presentation in families with NF1. It's a great question. So my experience is that one patient is not like the next patient in the same family. And so some patients will have a really aggressive plexiform neurofibroma that I might be treating, but their sibling might not have anything along those lines, or they might have a low-grade glioma or an optic pathway glioma that requires care. So again, it's not that one physical manifestation is going to be the exact same throughout the family, but to be aware of it is really helpful. Would you agree? Or
yeah, so variability, even though the penetrance is 100%, the variability is so wide, and it's not within each family member, or and the presentation is really patient dependent.
And then what age is NF1 usually diagnosed, and what are the first symptoms? So I'd say in families where you know that NF1 exists, it's diagnosed very early because people are having a heightened sense of awareness. Either they do genetic testing in the in vitro period, so they understand that, or as soon as the baby comes out, they're starting to look for some skin changes or things like that. For families that don't have the diagnosis of NF1, I think that's the most challenging situation, right? So you need to have that gatekeeper, that primary care provider, that pediatrician, or that family practice provider having a heightened sense of awareness that, hey, I'm starting to see some things, these don't quite add up, could this be something else? And so I think patients can definitely go on multiple years of life, even some into adolescence or young adulthood, without actually being handed that diagnosis. And you can imagine how frustrating that may be, especially when they're encountering other issues as they try to grow and develop. And then lastly, for a fairly robust NF clinic for peds, okay, gotcha, so this person does, but struggle with transitioning to adult care, absolutely. So we're gonna highlight that towards the end of this talk. I think that transition is probably one of the most difficult things that we face, and that obviously throughout our nation right now. All right, so going to our first case of good old Jonathan J. He's 7. He experienced some mild learning difficulties and clumsiness in school, which at that point had just been attributed to behavioral issues and not really formally evaluated. So this kind of goes to the whole point of when things are caught. He has a younger brother who's 4 and a sister who's 2. Annual physical exam. Now, pediatrician notes some axillary freckling and some small soft cutaneous nodules. Eye exam finds leash nodules, so that's really impressive that he was able to get to an eye exam for that. And then NF1's diagnosed based on clinical criteria, right? So we have our leash nodules, maybe small neurofibromas on the skin, axillary freckling. My guess is he probably also has capillae macules. And then the parents don't have any clinical characteristics of NF1, so he might be the first in his family. Further exam, again, does show the capillae macules, a little bit of that freckling, some hypotonia, which can be really common, so kind of decreased muscular tone, problems with coordination, no scoliosis here, and then visual, spatial, and processing defects. So at this point, the kids in clinic, I know we're not necessarily primary care providers here, but let's say they're referred to your institution. What's next recommended for this patient? We wanted to create more of kind of a panel discussion here. So I'd say, Rong, if you're seeing this patient in clinic who is referred to you with some potential here, what would you do next?
So, I mean, luckily, we do have a multidisciplinary NF clinic, so I think that's the first thing we would recommend. But Pretty much we would evaluate all of these things, and there's some things that we would probably do over others, including like we probably wouldn't automatically get an MRI scan, but I think we would definitely refer for growth and development, recommending school support, therapy that may be needed, and neuropsychological testing based on the criteria that was given before with some of the difficulties in school and learning and some of the hypotonia. And then we can talk a little bit more about the genetic evaluation and the need for that as well.
Yeah. And I'm going to spare Sunita since she's not necessarily seeing 7-year-olds in clinic right now. All right. We'll get to her soon, we promise. All right, so recommendations here. So genetic testing, which I'd actually like to, we'll highlight on the next slide too, but when is it needed, when is it not needed? Obviously, a new diagnosis in a family creates a lot of anxiety. Is it just the patient? Is it siblings as well? I feel comfortable using clinical criteria to kind of evaluate a family, but I can understand that others might want, a true genetic evaluation to understand, and we'll kind of go through pros and cons for that. Making sure that he has yearly eye exams, so at least for us and a variety of other people, vision changes might prompt a better evaluation for an optic pathway glioma or other abnormalities that can develop. We personally don't do routine brain MRIs for this. Some centers do, so it can be a little bit mixed. Neither, I would say, is completely right or wrong. Really understanding neurologic evaluations and developmental, behavioral pediatrics is huge. And then as he ages and as the family is just comprehending the diagnosis, really understanding the inheritance pattern, the risk for his future offspring. Obviously he's 7, but at one point he'll be 27, and like what does that mean for family planning for him? Making sure the school is aware for IEP, occupational therapy, speech therapies, and really understanding that there's a huge network out there to support families who have NF1, either themselves or their children. So the Children's Tumor Foundation, who we work really closely with, and then local networks as well. And then again, making sure we have those annual evaluations with a dedicated NF clinic to really go head to toe for the manifestations that can or have developed. And then this kind of leads to when is genetic testing advisable? So if you're not entirely sure of the criteria, maybe you see some clinical manifestation with a lot of capillary macules but can't quite see anything else yet, sure, doing a genetic test for that makes a lot of sense. For the unusual cases, a little bit later to diagnosis, if you feel like it would help inform therapy discussions, when the differential includes things that aren't on exactly NF1 based, family planning, siblings, and then also prenatal testing later in life. And then again, to highlight this genotype, phenotype, lack of correlation. So again, one genetic mutation does not mean you're going to develop X, Y, and Z, and so being very cognizant of that moving forward. Anything else you guys want to add? Yeah.
I think as we learn a little bit more about some of the genotype, phenotype correlations, because we are sequencing more, there may be I think we're learning, and there may be certain categorizations that are at risk for certain types of tumors, especially for this oncology audience. But again, that's something that is constantly developing as our sequencing and becomes more sophisticated and widespread.
All right, so what are the common missed opportunities that occur here? So I'd say the failure to recognize diagnostic criteria, especially for a new patient in the family who has NF1, underestimating the impact of mild developmental delays. Obviously, these can be instrumental into the development of the child, how they perform in school, how they perform, physically, things that we can address and help them with, delayed referral to specialists who can optimize care, inadequate family history, lack of coordination with schools, I think obviously would be very important to have. Overlooking the emotional and behavioral health components here, and then early diagnosis, NF1 complications, and then not referring to NF1 specialty clinics. So just like Arang said, if you have a patient in clinic that you're seeing, really trying to get them to that overall generalized care, because again, us on the oncology side are probably hitting one of the oncologic manifestations, but we want to make sure the entirety of the patient is addressed as well. All right, I'm going to pass the baton over here. I'm sure you guys are sick of my voice now.
So we're going to talk about the second learning objective, which will really be focusing on MEK inhibitors for the treatment of symptomatic inoperable plexiform neurofibromas. And this really has changed the landscape of how we treat plexiform neurofibromas and really bring it forefront to the oncologic centers. So we really, as Dr. Armstrong discussed, that NF1 is really a tumor predisposition syndrome, and that really works because the NF1 gene encodes for a protein called neurofibromin, and we know that if you lack neurofibromin, as looking at the picture on the right, you actually have hyperactivated RAS, and that pathway leads to proliferation and prolonged cell survival, and leads to tumors that are associated with NF. And that could be benign neurosheath tumors like plexiform neurofibromas, which we'll discuss more in detail, but other tumors as well, especially to recognize in the pediatric population, like optic pathway gliomas, as discussed, pheochromocytomas, and rhabdomyosarcomas. And so these are things that we will have to monitor for patients when we think about patients with NF1. So NF1 plexiform neurofibromas are what we're really going to be concentrating the remainder of this talk on, and these develop in about 50% of patients with NF1. And as discussed earlier, these may be thought of as congenital and really do manifest in early childhood. And what we've seen with the data looking at natural history studies is that they actually grow most rapidly in childhood. And so maybe this is the time when we can think about potentially mitigating with therapies. They are highly infiltrative, and so although they are benign, they can cause a lot of morbidity, and they can cause pain, disfigurement, and depending on location, can be life-threatening. Most patients with plexiform neurofibromas have more than one associated morbidity. And again, if you think about a plexiform that was shown in the earlier picture in this brachial plexus head and neck area, that can cause potential airway issues. There are paraspinal ones that can cause nerve dysfunction, and some very large extremity ones that can cause difficulty walking and a lot of motor dysfunction. And typically larger ones seem to be more symptomatic than smaller ones, although depending on the location, again, a small paraspinal one can have significant morbidities associated with it. But there are many that are asymptomatic, so not all have to be treated or treated with medical or surgical management, but we have to still be able to recognize them. And although, again, these are benign, they have a high amount of morbidity, and they can undergo transformation into atypical and then subsequently into malignant peripheral nerve sheath tumors. And the risk of MPNST in these patients are high, and they're higher in patients that we think have large plexiform neurofibroma burdens. So in terms of management, we can think about, do we observe or do we treat? And I think of that, you have to think about the symptoms that may present. So the age of the patient. Are these actually growing? Or are they staying stable? Are they causing potential for morbidity? So are they in locations where we worry that can cause life-threatening conditions? Or are they having a lot of symptoms, or are they progressing? And so these are things when we think, do we need to go on to treatment for these? And what are the treatments that were available for plexiform neurofibromas? So 10 years ago, really it was surgery. And surgery was actually relatively unsuccessful for many of these patients because, as you saw, these are very infiltrative, they're not discrete lesions, so they're very difficult to resect completely. And the recurrence rate after resection was quite high. And you can have sequelae afterwards. So now with medical therapies existing, we can consider potential medical therapies for these, and we'll talk a little bit more about the MEK inhibitors. So really the decision to treat or not treat kind of depends on, are they symptomatic? Are they inoperable? Is there significant growth? Is there significant potential for impact on function? Are they in high-risk locations? And again, the younger age typically tend to grow faster, but these are things that you have to consider. And the cons of treatment are thinking about some of the toxicities that we'll talk about in depth, the duration of treatment, which is also a question, some of the long-term sequelae that may occur, which we're still learning about, and the data that we still need to learn about some of these newer agents. So we'll go back to Jonathan, and now he's 10 years old, and he develops a slowly large diffuse swelling in the lower left neck and jaw area. This feels rubbery, sometimes tender, but it's growing, but slowly. The mass is non-resectable due to the location and the size, but it's causing a lot of cosmetic deformity and discomfort. And when they look at the MRI, it looks like a plexiform neurofibroma. And as you can see in that picture, that bag of worms, that there are these nodules that have these hollowed out lesions, so you can tell on STIR imaging, plexiform neurofibromas are pretty discrete on MRI. So over several years, this lesion causes noticeable facial asymmetry, difficulty in chewing and speech, neuropathic pain, and it's really becoming prominent. So at 15 years of age, there's progressive pain, functional decline, and it's really impacting his quality of life. So what are the recommendations at this point? So we already said that complete resection is not possible due to location. And one of the things that I want to highlight as oncologists here too is that we want to make sure that with some of these changes, you do want to make sure that they have not converted or risk of malignant transformation. So we talk from age 10 to 15. So during that time, it would be important to evaluate and make sure that we're not concerned that there's a degeneration occurring. But if this stays consistent with a plexiform neurofibroma, then I think at this time, systemic therapy is something that we should think about. So with the growing, the growing pipeline of agents and the understanding in terms of the development and pathogenesis of plexiform neurofibromas in NF1, several MEK inhibitors and tyrosine kinase inhibitors have been demonstrated activity against NF1. And those are kind of where the blockage in terms of where on this RAS-MEK, the MAP kinase pathway, these agents work. And there are two agents that are actually FDA approved for NF1. One is selumetinib, which was FDA approved for pediatric patients. It was originally approved in 2020, and most recently the age had decreased to 1 year of older with the new formulation that have now existed. And mirdametinib, which is actually FDA approved for adult and pediatric patients above age, was approved in 2025. And these are the two pivotal trials that led to their approval. So for selumetinib, it was the SPRINT trial, and for mirdametinib, it was the RENEW trial. And just to highlight here, selumetinib is taken twice daily, continuously for 28 days, where mirdametinib is also taken twice daily. The cycle is 28 days, but you're 3 weeks on, and 1 week you have a holiday. The primary endpoints for these studies were the same, and because these are slow-growing tumors, a volumetric analysis was used for these outcomes for these tumors, and a greater than 20% decrease in volume was considered a positive outcome. But primarily because these are benign tumors, really looking at secondary endpoints with decrease in terms of patient-reported outcomes was really pivotal in these approvals. So I want to highlight here some of the efficacy reports for the SPRINT and RENEW trial because they were very similar in terms of outcome. And first to note that these are partial responses. It's rare to see confirmed complete responses in these tumors. So usually it's mostly that they will shrink in size and the pain and the symptoms will improve. And they're durable. So you'll see about 50 to 70% of responses, of partial responses, 20% by volume. And just like because these are slow-growing tumors, the response is also slow. So the median time to response is actually about 8 months, where you'll originally see the tumor shrinkage, which is very different than what we see with many of our malignant cancers that we see in our clinic population. And what's important, again, in the pivotal trials is that the outcomes, the functional outcomes that are associated with reduction in pain, improvement in disfigurement, improvement in morbidity that really led to the FDA approval of these two agents. Because these are both MEK inhibitors, a lot of the side effects that are associated with these are class effects of MEK inhibitors, and we'll describe them a little bit more in detail in the next few slides. But really, I just want to highlight that most of the toxicities are low grade, grades 1 and 2, and the higher grades are actually quite low in percentage, and they really concentrate mostly around GI toxicity, rash toxicity, and we'll talk a little bit about some of the more worrisome toxicities and the management of that and why some of the things that we do in terms of following. But they are class effects, typically reversible, meaning once you stop, they get better, and then they can be mitigated through some measurements that you do knowing what these class effects are. The next two slides are really just the warnings and precautions that are part of the FDA label, and we'll talk about why we do some of the testings like echoes and things like that because of these. And this is really more for your guys's to know in terms of the warnings and precautions for both selumetinib and mirdametinib, which really are similar in terms of their toxicities.
Say, before we kind of jump into how we manage toxicities, I've seen a large array of questions coming through, and it might be helpful to address some of these right now as it's more on treatment response and things like that. All right, so I guess the first question that we haven't addressed yet is conversation about NF1 screening becoming part of the baseline testing for all newborns. As far as I know, it hasn't yet, and the things that are on the newborn screening are diagnoses that, when addressed at an early age, can change outcome, is my understanding. So I think even if we did diagnose NF1 at an early age, it doesn't necessarily change the overall outcome for that patient. We don't have a therapy that will make the NF1 go away. So as far as I know, it hasn't been part of those discussions, but I think increasing awareness and obviously evaluations would be very, very beneficial. It's an interesting one. Presence of a sphenoid dysplasia and an orbital plexiform in the same eye is having double pathology in the same eye affect the response to MEK inhibitors. I honestly have never had a patient with sphenoid dysplasia who then has an orbital plexiform. I don't think that would impact the response to MEK inhibitors, as in theory, these are kind of driven by a similar pathway. Have you ever seen that?
We've seen, I've had tibial dysplasia and plexiform neurofibroma, so they can have multiple manifestations. So it's really interesting because when you have a MEK inhibitor, it may affect multiple pathways, including learning disability. So some of the things that we're learning with many of these studies is adding on to see, how is this, when you block this pathway, how is it affecting some of the other manifestations of NF1? So I think this is still something we're learning as we learn more about these agents and more about the pathogenesis of the different manifestations of NF.
Yeah, and I'd add just to that our bone health kind of group through the NF Clinical Trials Consortium is really trying to understand the impact that MEK inhibitors can have on other things as well right now. So hopefully those trials will, the funding is always interesting these days, but can potentially move forward. Notable interactions from MEK inhibitors and other meds, and absolute contraindications to starting therapy. So yes, there are interactions. So CYP3A4 needs to be considered. Selumetinib is also coated in vitamin E, so we say that can increase bleeding risk if it's used in conjunction with other things like ibuprofen and things along those lines. So really just having a pharmacist kind of weigh in, because some of these kids will come in on a pretty deep medication list depending what their other problems are that require treatment. An absolute contraindication to starting therapy. We'll go through the evaluations we do, which are part of our toxicity evaluations, so things that we know MEK inhibitors can impact. I'd say maybe like severe cardiac dysfunction to me would be an absolute contraindication here. I'm trying to think of other big stuff. Obviously, if you've malignantly transformed or that tumor is not just a plexiform, I wouldn't recommend just starting a MEK inhibitor. That's why it's so important if a patient's coming into clinic with new signs or symptoms that we make sure we do that evaluation first. Any other absolute contraindications you guys can think of?
Just allergies to MEK inhibitors, but primarily I think it would be mostly cardiac and some potential renal functions as well. This is a very interesting question. So the treatment stopped after 2 years. Was the response maintained? So for the SPRINT study, they were not stopped after 2 years, and many patients remain on the SPRINT study. We have noted when patients do stop, they can regrow. For the mirdametinib study, they were allowed to continue, so many patients actually did continue after the 2 years. So this is a really good question. And I think something that we're still learning in terms of can you maintain, and there's a point where at some of these they may slow down as well on their own, and so these are all really, really good questions that we don't really have the answers for yet. Especially the second question, which says when do you stop a MEK inhibitor in patients with good responses? We don't know that.
Yeah, and I'd say pediatric is different than adult, so we might have some growing tumors where by the time they're in her clinic, things have kind of slowed down on growth. I would add that a lot of us, as opposed to stopping the med cold turkey, are now doing a weaning pattern or a plan if we feel like it's an indication to stop therapy to try to avoid some of those rebound things that we can see in pediatrics. And then the next is the $1 million question, which is the question between two agents, and I think we'll highlight that towards the end. So, At this point, I'm going to transition over to Sunita to kind of address some of the side effects that we see in clinic and her perspective, obviously seeing patients, getting the patient calls and what may be addressed. And I just also want to highlight, I think a lot of these side effects are pretty universal between kids and adults. Maybe the kids get more drier skin, adults and pubertal children maybe more of the acneiform rash, but the GI is pretty consistent, the paronychia, all those kind of things. So we'll hit to some direct management right now.
So yeah, when it becomes managing the adverse events from the MEK inhibitors in the adults and adolescent population, my approach is to be proactive and to be really patient-centered, understanding their current issues. And the most common side effects, as you can see on the screen for the adolescents and adults, are that rash, mainly in the acneiform rash. They may also have the paronychia, weight gain, and then fatigue and GI problems such as nausea, diarrhea, and abdominal discomfort. Some of the general dermatological care while receiving MEK inhibitor therapy. So we know that MEK inhibitors can cause just skin dryness. And so I try to review the skincare regimen with the patient, using daily gentle baths, mild cleansers, using like rich fragrance-free moisturizers, and then using consistent sunscreen protection is going to be very important to try to keep their skin safe. We don't do much of the bleach baths in our clinic. Is that a practice that you use in the children's?
Yeah, I don't routinely do it. For patients who are having issues, we will.
Yeah, I don't routinely do it either. It was part of some of the guidelines as a potential recommendation, but I think if they are having that's something that one can consider doing.
It's great to have options.
Yeah.
This slide here is a little bit busy, but I'll try to just highlight that there is a differences in how you manage the MEK inhibitor dermatological toxicities between the prepubescent patients and post-pubescent patients, focusing more on the post-pubescent patients as that's what I see in clinic. So for the acneiform rash, what I'll do is start with early education, gentle skin care, as I mentioned, and using a prophylactic approach with those patients, using like a topical clindamycin gel, as well as a doxycycline or tetracycline at 50 milligrams, so like lower dose, 50 milligrams daily for at least 3 months. Usually can be stopped after that because their bodies get used to it and don't exhibit the rash kind of past those 3 months. If the rash does develop early on despite this prophylaxis regimen, then we can utilize hydrocortisone 2.5% creams and triamcinolone 0.1% ointments as well, BID, and that can also help. So this might just be a slide that you want to take a picture of for reference for later.
And I'd say in the younger children, I don't necessarily prophylax, but when I have adolescents that are starting just like your adult patients, I mention that as a great opportunity to try to avoid the acneiform rash.
Yeah.
I don't know if you did the
Yeah,
same.
no, it is very stark. Like the young kids, they rarely have acne, and then the minute they hit puberty, like it's just definitely more common.
Exhibits more. Here, we're going to talk about management of MEK inhibitor diarrhea. So this is very commonly seen in our adult patients. For the GI issues, the way I would approach this, I would recommend early intervention. So using like an antiemetic for the nausea, using antidiarrheal such as loperamide as needed, educating them on how to stay hydrated during this therapy, and then making simple dietary adjustments. So I would often recommend trying the brat diet and avoiding like fried, fatty, or spicy foods, and increasing fluid, like I said, to help manage some of the symptoms and maintain like the overall quality of life. Probiotics can also be an option in trying those. Management of MEK inhibitor cardiac toxicity. So we would want to do a baseline cardiovascular assessment before starting a MEK inhibitor, particularly evaluating the left ventricular ejection fraction with an echocardiogram. I bring the patient in for a pre-treatment visit where I go through like their medications, their history, see if they have any blood pressure issues. And then I continue to do that routine monitoring throughout their clinic visits, assessing their blood pressure or for any assessment of cardiac toxicity such as shortness of breath, edema, palpitations. And then in our practice, we do repeat the echocardiogram every 3 months. If we were to notice that there is a reduction in the left ventricular ejection fraction, we would react kind of quickly. We do utilize our cardio-oncology team, and if there was an issue, we would send them to them, and they can, decide if they want to treat with cardioprotective medications. But most importantly, we would want to stop the medication until that has recovered to like a grade 1 and symptoms have improved, and then we can re-challenge at a lower dose. Obviously, if it's anything like grade 4, discontinue the medication.
Yeah, and I would just add the grading's important here because like, let's say you start at 58%, you got down to 55%, you don't need to hold the med. Like, I think we can trend that okay, especially on our end. But when you're starting to get below 50% or greater than a 10% decrease from when you were starting, then I think consideration definitely needs to go into play.
Yeah, or if they become symptomatic.
Yeah, for sure.
And then management of MEK inhibitor ocular toxicity. So we know that with some of the MEK inhibitors, like mirdametinib, there has been some ocular toxicities. So part of my pre-treatment visit with the patient, we will also make sure that they get a comprehensive eye exam and follow with ophthalmology. And most of these patients with the lich nodules, they already have established with an ophthalmologist. So we just stay in close communication with those providers.
Awesome. And then in our next slide, we'll kind of go through, the 2 options that are FDA approved, but I saw some more toxicity questions kind of pop up, and you guys are a very awesome audience, really asking really good questions. Let's see, so grade 3 CPK elevation cases with clinically significant rhabdomyolysis seen. So for me, I don't always have a correlation between the lab and the clinical presentation. So often I'll see a really high level, which the patient may be asymptomatic. However, if the patient's having symptoms, it's also important to draw a level and also to understand the grading for this. I've definitely had referrals or things where CPK may just be a little bit above the upper limit of normal and people like hold med, and that's not really indicated. This is an extremely expected toxicity. So what is truly grade 3, how to hold, how to dose reduce and things. Have you, and sometimes hydration, admission, it will require more intervention and things.
I've actually not seen any rhabdomyolysis with the CPK elevation. So we see it commonly, usually grade 1 or 2. If it's 3, we would hold it. And this is again using the CTCAE guidelines, but again, it's usually asymptomatic. I don't know if you've seen anything in the
I have
adults.
not. I mean, if they are slightly elevated and the patient asymptomatic, we may still offer just to give them some hydration, repeat the lab within a week, and if they're fine, we just continue the medication.
Yeah. How do you manage weight gain on MEK? Seen it more in my practice, can be significant. Agree. I think the really hard thing in pediatrics is patients are supposed to grow and gain weight, and so really understanding what's off the growth curve, what seems different. Is it weight gain? Is it edema that you're seeing, which we know can be really common with these MEK inhibitors, if it requires a dose reduction or things. And then also, I know it seems odd, but I've had some like oral plexiforms where the kids just didn't want to eat as much, and then they hit, then they feel a lot better on a MEK inhibitor, and now they're like eating more, and part of it's, clinically they're feeling better and able to gain some of that weight versus just a medication thing. But I think dose adjustments, dose holds can be helpful, but this is one of the trickiest parts in pediatrics. And sometimes if it gets really bad, you can consider a different MEK inhibitor, which we'll talk about, but not always beneficial for a side effect. What do you do? Yeah.
It is a hard one to see, and I've seen it, but like Dr. Armstrong said, I definitely would make sure that there's no other etiology for the weight gain. So making sure when you look at their echoes, their kidney function, because we do see edema as a common side effect with these MEK inhibitors, to make sure there's nothing else going on. But it is weight gain, and especially in our adolescent population, this can be a serious concerning side effect. So there are times when we do try to do dietary management, but I've had patients who've asked to come off because of the weight gain, and we do that in a slow manner in terms of weaning. Now we'll do this weaning process for this. And then sometimes we have been able to restart with a lower dose, and that seems to also help.
Yeah, and to just add to that, also maybe getting endocrine involved. So do you have how's your height gain? Do you have precocious puberty? Do you have something else going on that may be influencing the weight? I think is really important.
Yeah, I was going to add with our adult patient on MEK inhibitors, we have seen some gain weight, and we would refer to like an endocrinologist to help, or just a primary care doctor, and they can discuss options for weight loss managing, in addition to exercising.
And then when we can spread out the echo interval, I know everybody's practice is different. Usually I'll do every 3 months for the first year, and then if I'm seeing some nice stability, I'll go out to every 6 months thereafter. And on the adult end, I've talked to my colleague Angie, you can't always get insurance approval for some of the echoes, so I don't know if you...
We try to get it every 4 months, along with their repeat MRIs while they're on therapy, so we try to join those together. And I haven't had much insurance denial so far on the echocardiograms.
I mean, it is part of the label, so I feel like that's one thing that we haven't had difficulty with. Usually after 2 years, I'll go to every 6 months, and then I really haven't increased the frequency from 6 months from then on. And that's usually correlating with the time when we do the imaging.
Yeah. And the last one, if one patient does not tolerate due to pancreatitis, and I'm not sure if that's been reported, but maybe like other GI issues on selumetinib due to chance of regrowth, would it be better to switch to Mirta, or is there not better tolerability by switching and same effects? So I feel like we don't fully know the answer to this question. And in general, the question is saying if we have a really bad side effect to one MEK inhibitor, are you going to have it with the other MEK inhibitor? We feel like it's a similar class of medication. The side effect profile pretty much overlaps with one another. We have had anecdotal reports where switching has helped in this scenario, so I think it can be offered, and definitely if the patient's in true need of treatment. But it's not a guarantee that you're not going to have the same thing otherwise.
Yeah, just by anecdote, I've had a couple where we've switched and it seems to help, but there's no, I think the bottom part is that we have no head-to-head comparisons and there's no data on MEK switching. But I think it is done in practice, so I think there's some things that we'll learn as time goes, because there's just like with other class effects too. And I think the other thing to think about, yes, these are MEK inhibitors. These two are the two FDA-approved MEK inhibitors specifically for NF1 and plexiform neurofibromas, but there are other TKIs that have been evaluated, including cabozantinib. There are other things that are also being evaluated in clinical trials. So I think MEK inhibitors are not going to be the only option, and there are other things that one can consider as well.
And before mirdametinib became approved in the adults, when we were using selumetinib, and we still have a handful of patients on selumetinib. For the patients that did end up making that switch, we didn't really see that the GI stuff got any better, about the same, but we knew how to manage it from the selumetinib, so we just kind of continued the same regimen for it.
Yeah.
So not necessarily worse.
And I think that kind of highlights the bottom box here, that we don't have head-to-head comparisons right now. We're all getting our own clinical experience maybe, and obviously in discussion with colleagues across the nation as well. So really when I have like a patient walk in who's new, who wants to start MEK inhibition, I personally don't recommend one drug over the other. I just go through the differences. One of the questions here was with the sprinkle formulation going down to a year, if that changes anything. Previously, mirdametinib could be formulated to be liquid, so for patients who couldn't swallow pills, that would be an option that we might go for. And now obviously we have the sprinkle option as well. I highlight the differences, continuous versus that 1 week off, how long we have FDA approval, and then some brief data from the studies, but I think it's hard to do a head-to-head comparison through these trials for a lot of different reasons, which we won't go into right now. And usually families can make the decision by themselves with me just kind of providing the overall difference. And we always say if one doesn't quite work out for you, we can, figure out if we want to go to the other. But any other approaches that you've been using?
I mean, I think in patients that are already on the drug too, so I won't switch.
Right.
Like I don't typically switch because something else has been approved. So if they've already been on it and tolerated, we continue on it. I think I've had some adults that were on selumetinib that we were able to get just through insurance before mirdametinib was approved, and they've remained on it. I think part of it would be in terms of labeling, if there's an adult, because we still see 18 and above in our pediatric population still, and so that's something to consider now that mirdametinib is approved. And just like the sprinkle formulation was literally like a month ago.
Hot off the market,
it's a hot off the presses, yeah.
Yeah, the press. Hot on market. Yeah, and then maybe if you can just go to the next slide.
Oh, yes, sorry.
Yeah, I think, again, some of us will do things a little bit differently. Some of it's based on the trial approaches, like how often do you see patients who are on MEK inhibitor therapies. I try to do monthly initially just to go through side effect profiles, lab tests, and then at that 3-month mark, we'll do a repeat eye exam and echo. And then I personally image every 6 months unless there's an indication to do it sooner. So if you're by a vital location and you really want to understand the response, obviously you can image sooner. And then as time moves on, definitely spread some things out. I will say I have patients who travel multiple hours to come see us, and so sometimes a monthly visit can be a little bit hard. And so trying to coordinate local lab draws and a telemed visit or things like that definitely have been used. Trying to think if there's anything else big from what you guys would do for evaluations, but.
No, pretty much similar.
And I think, in terms of, as oncologists, we're very used to coordinating the visits to try to minimize things. So trying to get the echo, ophthalmology, MRI, oftentimes on the same days, which is challenging, but I think we've done it with a lot of our other patients.
Yeah.
And just like, these are slow-growing tumors, they respond slowly, so we do, the first imaging time point is typically not super early because we know that it takes some time for these effects to take place.
I do our 2-week medication side effect check just over the phone, and then stay in touch with that patient if something's going on. Either just call them or through the MyChart and Epic messaging, and then assess their pain. So I usually just have them tell me how they were baseline, and then continue that conversation.
I think that's a really nice segue to the end of this talk, which has to go with transitioning patients from pediatric to adult care. Because as Rong alluded to, we try to coordinate everything on the pediatric end. We're really nice. Okay, gotcha. We're really nice, I feel like, in our clinics. On the adult end, sometimes it's a little bit harder to coordinate unless you have a champion in clinic like Sunita and things like that. And in the essence of time, because I know we're almost there, we're actually going to pass. We have a video, but we're going to pass through it. Keep clicking along. Sorry, we do appreciate Renee. And just to kind of go through the differences and transition, and I think I'll just highlight, pediatric is family-centered. I think you guys all know that. We have more time for our patients just because we have less patients. I wouldn't say it's because we're better doctors or anything, but our, we see up to the age of 18, or I do 20s, you do up to 30s and stuff. But those clinic visits can be a little bit longer, and we really do help coordinate care and kind of hold the hands of patients as they move through. And if you want to give the team your viewpoint of the adult care.
So we know that this transitioning is critical, that the adult model looks often different from the pediatric. Our greatest focus is on patient independence, shared decision making, because now they're adults, they can make their own decision. And then we continue into that long-term surveillance. Here, there are 6 core elements of healthcare transitioning to the adulthood program. I just want to jump in and highlight that my involvement usually begins at the transition planning meeting, where we review all our patients who are ready to make that transition. And we discuss their treatment plans and ensure that their medical summaries are up to date and that we know what the patient's well aware of, what that transition will look like on the adult side. There are some barriers to a smooth NF transition, such as the limited staff available, fewer adult providers, as someone mentioned, different care approaches, sometimes insurance challenges, and lack of some support, such as legal support. So understanding these are, barriers is going to help us to better plan for our patients.
I think the earlier we can think about transition, the better, to really set these patients up on a nice platter for the adult side. So we'll do, we meet like every other month between peds and adults for our NF patients to understand where they're at, readiness, who's calling for prescriptions, who's scheduling appointments, what can we do to ready them when they're younger, so then when that transition happens, that they'll be ready for it. But we definitely acknowledge that it's not easy, and it really requires advocates on both ends. And I think that's where some of the limitations can definitely arise, which I know happens a little bit in the DC area.
Yeah, and I know, someone was asking, we have a great peds NF clinic, but we don't have a partner. And I think for us, we're a free-floating children's hospital, and so it's difficult, which I feel like it's difficult to begin with, but at least at WashU, when there's an adult and ped side that are together, maybe the transition might be a little bit harder. So it is a challenge for our patients. That's why I tend to hold on to them long, which may or may not be the right thing to do, but finding a partner and finding the right people to do it, and I think we have to work towards that, and finding the places that the patient can attend, which would either be Baltimore for us or Virginia. And so it's a challenge, and I think that's something that we have to work with our patients and our partners at these other institutions to help advocate for our patients so these transitions can be smooth. And it's important because, honestly, I shouldn't be taking care of some of the patients when they're, past probably 35 or 40 and for their best setting, and for the, institution as well.
I'll try to just quickly go through the end here because I know we're over time, but here's a QR code. I think you guys might have a copy of slides too, but tools to aid in transition of care that obviously will be helpful. I think we've addressed a lot of the questions in real time. There was one more popped up, so we'll see if we have time in the end. And then just understanding the SMART goals here, which is really, the essence of this talk is to get you guys ready to provide the best care to your patients and for that transition period. So SMART, measurable, attainable, relevant, and timely are intended to be actions you can take back to your clinical practice starting tomorrow. And then hopefully we can hear Rennie. I could skip over her, but she has a message to you guys, which I think is really great, and potentially we can just play it and end with that.
Is thank you more than anything. I know that nurses are often the front line in a very busy clinic. Unfortunately, healthcare is very different now than it was 50 years ago. You can't spend a lot of time in the exam room, so you have to be very finite. And I don't think we have the ability to say how important nurses are in our care. I mentioned in an earlier question that they're kind of like syrup that oozes into the entire continuum of care in a good way because they fill in the gaps and put out the fires for us. And so I don't think nurses get enough credit for what they do in some of these very, very complex situations that have to do with managing NF care. And so families like ours, if we don't get a chance to tell you in the exam room, we are so grateful for you and hope you'll stick with us. We know we're hard cases and we're not the easy cases, but you're a lifeline and we really, really do appreciate you. Thank you.
Yeah, and I think it goes without saying that we're very appreciative up here, and obviously the care for this patient population requires a village, so thank you for what you do. Additional resources can be found on www.cecconcepts.com. You can claim credit here in person live stream. I can leave that up for a sec. And we might be able to ultimately end here. So thank you guys, obviously, for participating today and for the audience participation, which was really great. You guys are giving physicians a run for their money because I feel like we don't get this good of questions when we otherwise give talks here.
Thank you.
Thank you.